everybody. Welcome to our University of Washington Cardiovascular Grand Rounds. It's my pleasure today to introduce my friend and colleague, Dr. Stephanie Cooper, who many of you know well, and is Clinical Associate Professor of Medicine and Cardiology here at Harborview Medical Center. So Stephanie, I'll keep this short, Stephanie, don't worry. Stephanie received her MD from UCSF before coming to Seattle to complete her cardiology, nuclear cardiology, and interventional cardiology fellowships, followed by practice in the community for almost a decade before she returned to UW for a palliative medicine fellowship. And since then, she's been on our faculty and closely involved in building our heart failure care program at Harborview, among many other aspects of what the section does. Stephanie is among the most thoughtful and dedicated cardiologists I know. And today she's going to help us grapple with a problem that has been increasingly common in our practice. So her talk, Methamphetamine in the Heart, a historical perspective update and considerations of care, is timely and increasingly something that we need to know more about. So thank you very much, Stephanie. Take it away.
Thank you, Greg. That was very nice. And thank you all for being here. There we go. I have no disclosures. I'm going to start with a couple of cases. So a 37-year-old man that was admitted to my service a few years ago with several significant comorbidities, biventricular dysfunction, and he was admitted with acutely decompensated heart failure. So workup was negative other than a positive tox screen, plus he freely admitted to smoking meth daily. And he had some mild lab perturbations other than a hemoglobin A1C, which was markedly elevated. And then another patient whom I just met a couple months ago, 40-year-old man that was admitted to Harborview for pulmonary abscess and bilateral empyemas, which were thought to be chronic. He was discharged from Harborview to respite for palliative care because he was also in severely acutely decompensated heart failure and thought to be too high risk for VATS for his empyemas. And it was thought that given that his life was going to be limited due to non-definitive management of this empyema. When I met him in clinic, he was massively volume overloaded, wheelchair bound due to gangrene in his toes, as well as tree trunk legs, and told me he wasn't going to come into the hospital. This is his initial echo, which was estimated to be an EF of 12%. Okay, I'm going to talk about the history of amphetamines and methamphetamine usage in this country, so it turns out there was a previous epidemic of amphetamines before this one, and the beginning of which really shares some similarities to the current opioid epidemic. Then I'll talk a little bit about biology and cardiovascular pathology, and then taking care of our meth cardiomyopathy patients. So Ephedra is a plant that was the source of a plant-based medicine for thousands of years, apparently, for respiratory ailments. And the active ingredient of ephedra, ephedrine, was isolated and synthesized in the late 19th century. And then in the next couple of decades, other easier ways of synthesizing it, as well as its analog, methamphetamine, were worked out. This chemist was looking for a bronchodilator and ended up selling his patent to SmithKline French that put the amphetamine into an inhaler. The original market indications for which they marketed this were few, and the market share was pretty small, but they were looking for a bigger market. And they ended up funding a psychologist who had some interesting ideas about depression, namely that there was a mild depression, or anhedonia, he termed it, which was sort of a psychogenic tiredness that he thought was due to a suppression of the natural drive to action. He blamed it on a CNS hormonal imbalance and thought that amphetamines helped correct that. With this indication, SmithKline French marketed it heavily to doctors. So these are ads that were in medical journals at the time. And basically the prescriptions for it took off. So it wasn't prescription regulated, but doctors prescribed it in massive quantities and sold it out of their offices. Over the next 30 years, the prescription incidence continued to rise, and eventually the AMA would also approve it for weight loss, although there hadn't actually been studies demonstrating that per se, and that just further accelerated the use of amphetamines. It seems to me that a lot of physicians maybe just were satisfied to be able to prescribe something to patients came into the office saying that they were tired and didn't really like their day-to-day life. I agreed that would be satisfying. It was also used in the military. So a lot of you know the story about France not extending their line of defense at the French-German border across the Ardennes because it was thought that the Germans would take at least 10 to 14 days to traverse the Ardennes, thus giving them time to react. Turns out the Nazis crossed the Ardennes in 3 days. And this has largely been attributed, apparently, to the fact that they had methamphetamine in their kits. With eyewitness accounts of the Nazis behaving like berserkers. So the Royal Armed Forces and the US Armed Forces heard the success and put it in their kits. And there were immediately reports of concerns about abuse and untoward side effects. And there was a study of military prisoners in 1945, I think it was, that 25% of the personnel were eating the amphetamine out of their Benzedrine inhalers. It's worth mentioning that Germany actually figured out that it didn't make their soldiers better, it made them worse, more impulsive and less good decision makers, and took it out of their kits by 1942. The Brits also took it out of their kits in the mid-40s, but the US continued to supply methamphetamine through Vietnam. Japan also produced a lot of amphetamine, and apparently there are reports that they injected their kamikaze pilots before their final flights. And after World War II, there was a flood of amphetamine onto the civilian market with what was thought to be a significant meth abuse epidemic, which was apparently shut down by a public health campaign. And Japan hasn't really had trouble with it since. SmithKline French's patent expired in the 50s, and they added barbiturates to it to make the medicine even more attractive and eliminate some of the untoward side effects of amphetamines like shakiness. And it, like I said, really took off for diet indications. It was a favored prescription for women, and by 1960, 85% of prescriptions were given to women, and a woman was twice as likely to walk out of a primary care physician's office with an amphetamine prescription. It again continued to increase in amount produced, extraordinary numbers of amount produced by the known producers. Meanwhile, the FDA had required prescriptions in the 50s, which didn't do anything to reduce prescribing, but it did create a black market. And so organized crime, namely motorcycle gangs on the West Coast, became interested in diverting it and selling it. And they actually learned how to produce it as well. At the time, amphetamines were called crank when they were sold on the street because it was kept in the crank cases of the motorcycle cases of the motorcycle gangs. By 1960, 5% of the population of New Yorkers 14 years of older had received a prescription in the past year, and most of them, or many of them, admitting to taking it for non-medical use. And a lot of popular figures were using it, politicians, athletes. I mean, it was mainstream. JFK was getting injections. Anthony Eden took methamphetamine, and some people hypothesized that contributed to his poor decision-making during the Suez Canal crisis. It is interesting for me to think about what the possible kind of cultural and anthropologic implications of this were. This was mainstream use. There was also this huge burgeoning black market of it, but it was everywhere. And I think our parents and our grandparents possibly were taking amphetamines, and it seems like this history has largely been lost. But in any case, it became more and more evident that it was problematic, and became obvious that it was addictive rather than just habituating, as had originally been reported. And this resulted in more media attention and subsequently congressional hearings at the end of the 60s to specifically address the amphetamine problem. And it was the amphetamine problem that resulted in the establishment of the DEA schedules so that amphetamine could be put into the DEA schedules. This did work to decrease amphetamine prescriptions, but by now a huge market for amphetamines had already been created, and organized crime simply took over. So what does the meth epidemic look like now? As I said, prescription use went down 70s, 80s. But when I moved here in the 90s, there were a lot of small-time labs around here blowing up all the time. So 80s and 90s saw the rise of small labs that could produce about 5 pounds at a time. But organized crime in Mexico got interested, and over the last 15, 20 years, production has largely moved to Mexico. Originally, they imported the precursors of ephedrine and pseudoephedrine from all over the world. But as those became more tightly regulated internationally, they figured out other precursors in which to synthesize. So there's this phenyl-2-propanone precursor, which is unregulated, as well as precursors that are unregulated. It is currently produced on industrial scale, tons at a time flooding across the borders. And the meth labs on the West Coast anyway, and largely in the US, have largely gone away because of the flooding of the market by the Mexican organized crime. So this is demonstrated by seizures of meth. This is San Diego seizures of meth over recent years. This is US seizures of meth, this pink line. These bars are meth lab incidents, which have declined to almost nothing. Although you notice that on the West Coast, so the darker the color, the more meth lab incidences. On the West Coast, the meth labs are going away, but they are popping up in the West Coast and East Coast. It used to be thought that meth was a West Coast problem because it was, but that's no longer the case. The meth coming from Mexico is also very pure and very potent. And I don't have a slide, but it's also very cheap. So there's a lot of meth, it's cheap, it's pure. And these are meth seizures across the country. It's not just a US problem either, it's a global problem. So these are seizures across the globe, in Europe, in Middle East and Southwest Asia. Meth has been a problem in New Zealand and Australia for a long time, and somehow they've kept the incidence relatively steady. It's still mostly produced in the Americas. And of course, this increased production and cheapness has resulted in increased use. So there's a national survey every year of drug use in America, but the people they survey are civilian, non-institutionalized, and housed. So obviously the meth use incidence is quite a bit higher than is being reported by the survey. But in any case, it's estimated by the survey that 0.6 of the US population, age 12 and older, has a meth use disorder. This is up from 0.4 just a couple of years ago. It turns out that there's a stimulant, prescription stimulant use disorder as well, which makes sense. And that actually had to be separated into a separate category. And this represented the number of people who were thought to have used meth in the past year, 2020, as opposed to the number misusing prescription stimulants, which by the way, can be ground up and injected. And I think it can be burned and smoked as well. This is meth use by state. The orange and blue is heavy use. And again, it's moving east. This is a drill down of that same survey. And what they noticed here is that in the year of these light blue bars of 2018 to 2019, there was a marked increase over the previous 3 years, which are the dark blue bars. They also noticed there was increased riskiness of meth use, including injection use, combined with other substances, which frequently are other synthetic substances like fentanyl, and disturbingly a 300% increase in meth use disorder in young adults. They also noted that although meth had previously been perceived to be a white male drug problem, that Black substance users have accelerated their use of methamphetamine. So it's no longer, the male to female ratio has equalized, and other people other than white males are using it. This, of course, has resulted in increased overdose deaths by meth, increased total deaths by meth, and increased hospitalizations. In this study, which is a national study on hospitalizations countrywide of amphetamine related versus non-amphetamine related, the in-hospital mortality was higher if they were amphetamine related. And this is an interesting study that came out of California just this year, where they looked at all of the admissions for heart failure in California and compared the meth heart failure to the non-meth heart failure. And what they noticed is that the total heart failure admissions represented by this red bar were less in 2018 than they had been in 2008. But there's been a steady incline in total heart failure admissions since 2014, which is partly or largely driven by this purple line, which is increased incidence of meth heart failure hospitalizations. What they noticed in this population is that they were more likely to be young, that their comorbidity index by several measures was less than the non-meth heart failure related admissions, that their in-hospital mortality in this study was less, but that there were many more hospitalizations per patient. The length of stay per hospital stay was higher, and a really dramatic increase in the cost of meth heart failure hospitalizations. They also noticed that the meth heart failure patients were more likely to be homeless, use other substances, and be poor. And this UN study noticed that they are more likely to be unemployed compared to, this is all meth users, not just meth heart failure, but they're more likely to be unemployed than full or part-time, and less likely to be college graduates in these declining levels of education. They're also more likely to have been incarcerated and to have had suicidal ideation the previous year. This is a similar study done by a VA in San Diego that looked at all of their heart failure versus meth heart failure admissions over a 10-year period. And this is the incidence of their heart failure admissions that are meth heart failure. And in their case, they noticed increased mortality, which is this dark line from the meth heart failure admissions than the non-meth heart failure admissions. They also noted an increased incidence of homelessness, PTSD, depression, unemployment in their meth heart failure versus their non-meth heart failure patients. So conclusions number one, there was a previous methamphetamine epidemic and amphetamine epidemic, and it appears to have largely been generated by pharmaceutical advertising, physician prescribing and distribution, and military use. I don't know. I wonder if it's a stretch to suggest that the market for amphetamines and methamphetamines was created from that first epidemic. But in any case, meth use is on the rise dramatically now. Psychosocial and economic factors are associated with and likely contribute to meth use. And similarly, meth use results in a huge social and economic impact. So I'm going to switch to talking about the biology of meth. So the difference between methamphetamine and amphetamine is a methyl group, which makes it more lipophilic and thus able to freely penetrate the blood-brain barrier. Plasma half-life is usually 5 to 6 hours, although you can prolong the half-life by alkalizing your urine. Apparently, a lot of substance users know this and eat bicarbonate. It's metabolized in the liver, and it creates a euphoria that is short-lived compared to the longer-lasting effect of the catechols, i.e. the stimulation and alertness. So for that reason, apparently a lot of substance users binge use the meth over a day or a few days to reproduce that euphoria. It's also highly physically addictive, although that nature of the addiction is not completely worked out. So the way it works is that it binds at the cellular membrane, binds the monoamine transporters and exchange transfuses into the cell with monoamines. It then binds the vesicular transporter and pumps the monoamines out into the cytosol, where it stabilizes their high levels by also blocking monoamine oxidase. This results in high cytoplasmic levels of monoamines, which are then reverse diffused out. It turns out that this binding of the receptors causes damage to the axon terminals and dopaminergic and serotonergic axon terminals throughout the brain. And there's quite a bit of evidence that it results in a persistently reduced dopamine production, as well as persistent reduced expression and abnormally functioning dopamine receptor transporter. It also causes gliosis and neuroinflammation, partly on that basis, and it results in large amounts of reactive oxygen species being generated, resulting in oxidative stress and apoptosis on that basis. It also appears to cause direct neuronal cell death, which is thought to be related to causing mitochondrial damage. You can imagine that this neurotoxicity results in a significant number of neurobehavioral perturbations in meth users. And it's been noted that they indeed show emotional dysregulation, cognitive dysfunction, in particular reduced executive functioning, which is an important thing to consider when you realize that we're taking care of heart failure patients. And by all measures, taking care of heart failure requires a high level of executive functioning. It can result in increases the risk of Parkinson's and other movement disorders. And of course, it results in a psychosis, which can result in the need for long-term antipsychotics. It causes functional and structural changes in the brain. In other words, chronic meth users have brain damage. And this is not to diminish them, but I think this is something that we as cardiologists taking care of patients with meth addiction need to understand. It needs to factor into our perspective of how we care for them and what we can expect them to do. It also means that just simply telling them to stop using meth isn't going to work. Okay, moving on to cardiovascular effects. So the two systems that meth is toxic to is this specifically, particularly toxic to is the CNS and the cardiovascular system. In one large autopsy study, cardiovascular toxicity was the second leading cause of death. It's known to cause a number of catastrophic vascular events like hemorrhagic stroke, which it increases the risk of, aortic dissection, coronary events, placental abruption, and chronic meth use causes premature atherosclerosis, cardiomyopathy, and pulmonary hypertension. So the means by which it produces this toxicity is thought to be multifactorial, and obviously a large contribution is by the sympathetic activation. But there's also evidence of cardiovascular inflammation and direct cell toxicity and apoptosis. So meth doesn't just bind the monoamine transporter receptors. It also has affinity with other receptors at physiologic concentrations. So there's been several autopsy studies that have demonstrated premature coronary artery disease. In this study of almost 1,000 patients, 20% of the patients of mean age of 38 had severe CAD. Also, all autopsy studies have shown that the hearts are generally larger and have a lot of fibrosis. In this study of 100 patients, 68% had some sort of cardiovascular pathology or another with, again, focal necrosis and fibrosis. The histopathology in both animal studies and humans in the heart is perivascular and interstitial fibrosis, myocytolysis and vascularization, myocyte atrophy and hypertrophy, contraction band necrosis, and in animal models, it appears to disrupt mitochondria. This series of endomyocardial biopsy that a lot of you know, it's a 30-patient series that came out of Germany, where they biopsied the hearts of meth users, noted that all of them had some degree of fibrosis, but the degree of fibrosis seemed to correlate in this descending column with the duration of use of methamphetamine. They all also demonstrated inflammation, but the degree of inflammation did not seem to correlate with extent of use. And this is an autopsy study in which 34 patients who died not of cardiovascular toxicity, generally of accidental death, and all of the hearts were noted to be larger and to have, this is collagen staining, perivascular collagen staining, interstitial fibrosis, and fibrotic remodeling. This is the percent fibrosis in the meth hearts versus their non-meth heart case controls. So what is the incidence of cardiomyopathy and cardiovascular complications in meth users? You know, no one really knows, but that last autopsy study suggests that we could assume that virtually 100% of patients have some degree of cardiovascular pathology. Whether they actually present with clinical cardiovascular disease, it is difficult to know. But again, I think we can assume that chronic meth users all have some degree of at least myocardial fibrosis as well as vascular damage. In this study of 4,600 meth users in a California hospital, they culled the 782 patients who received an echo, and half of them had the echo demonstration of cardiomyopathy. That study also noticed that those patients with echo evidence of meth cardiomyopathy were more likely to be male and hypertensive and have alcoholism, whereas the women in this study who had pulmonary hypertension were more likely to be, the patients in the study who had pulmonary hypertension were more likely to be female. There has been a theory proposed that there's possibly a cytochrome enzyme polymorphism that could contribute to susceptibility to clinical presentation with cardiomyopathy, but this hasn't been proven. So as I said, there's a lot of vascular events that happen with meth. This is, of course, largely attributed to sympathetic stimulation. So after the use of meth, there's an immediate rise in heart rate and blood pressure. And we've all seen patients who are admitted with hypertension. They can be admitted with hypertensive crisis and hyperthermia. But there's also evidence for catechol-independent vasoconstriction via endothelium release or arterial TART1 signaling. Further, there's been patients who presented with coronary vasospasm that is insensitive to nitroglycerin, suggesting endothelial dysfunction. And there's was a contrast echo study that seemed to demonstrate reduced microvascular flow. Also in mouse models, there's evidence of reduced cerebrovascular flow, chronically reduced cerebrovascular flow that appears to be due to microvascular damage. So this is a little break from my my words. This is a patient that we admitted to Harborview several years ago with ST elevation and chest pain, and this was his left heart system. His right heart system looked similar. Left coronary system. His right coronary system looks similar. And this is his. This is after nitroglycerin and verapamil. So this is so I could take a sip of water. Okay, meth also causes pulmonary hypertension. So it's been demonstrated on PET studies that injection of meth results in accumulation of meth in the lungs, and the pulmonary endothelial cells the pulmonary vascular endothelial cells are known to internalize meth and metabolize it by carboxyl esterase 1. There was one patient series that showed that the majority of patients with pulmonary hypertension had a genetic alteration in carboxylesterase 1 that resulted in it being less active. So there's now this theory that patients who develop pulmonary hypertension do have a genetic susceptibility and are probably more likely to be injection users. Meth also causes arrhythmias, increases the risk of sudden death. Probably some patients who are thought to have overdosed actually died suddenly. Probably in large part, this is related to the cellular disarray and fibrosis and inflammation that we saw in the autopsy and biopsy studies, but there's also some evidence of electrical remodeling with changes in the potassium and calcium channels in animals. They also have been shown to have increased shock impedance, which again, I assume is due to the myocardial fibrosis and in some cases prolonged QT. So cardiomyopathy, how is it that that there's so much replacement fibrosis and inflammation, et cetera, in the heart? It's thought to be multifactorial, maybe, possibly one of the main reasons is ischemia. So you can have large ischemic events due to coronary occlusive events, spontaneous coronary artery dissection, atherothrombotic rupture from the premature coronary disease, or multiple small infarcts over time. We've all admitted a number of patients who have small troponin bumps in the setting of amphetamine use. But there's also possibly direct vasoconstriction that's catechol independent, resulting in ischemic events and endothelial dysfunction. Obviously, the catechols are probably playing a part because when you inject, when you take meth, you get an immediate rise in heart rate and blood pressure. Can't remember if I already said that. There's also a lot of evidence that meth results in an inflammatory response, so increased expression of pro-inflammatory markers and that activate inflammatory cells and then release of inflammatory mediators. Meth has been shown to damage the mitochondria of T cells, and the atherosclerotic plaques of premature coronary artery disease meth user patients have the inflammatory phenotype similar to vulnerable plaque in our other atherosclerotic patients. But most intriguing to me is that it appears to also be directly toxic. And I'm wading into some cellular molecular biology here now, which I'm not very fast at discussing. And it's been 30 years since I've been in the basic lab. So a little bit of grace, but basically it's been demonstrated in both humans and animal models to increase the expression of apoptotic proteins, decrease the expression of anti-apoptotic proteins, result in perturbations in autophagy and the ubiquitin proteasome system, resulting in increased apoptosis. And as I mentioned before, cause myocardial damage in neurons. This is one avenue of exploration that people are looking at, which is that in animal models, meth attenuates expression of the regulatory protein FIS1, which is a mitochondrial fission protein, resulting in abnormally fused mitochondria on electron microscopy and perturbed tubular network in the mitochondria. FIS1 overexpression, on the other hand, attenuates the meth effect on the mitochondria. It appears that in both mice and human hearts, the FIS1 transcription regulator, CREB, cyclic AMP regulatory element binding protein, so attenuates the CREB, which is a transcription regulator of FIS1, and attenuates the phosphorylation of CREB. And apparently there's a separate, having nothing to do with meth investigation, there's a separate animal model for dilated cardiomyopathy with mitochondrial dysfunction, which is a deficient phosphorylated CREB. Finally, meth suppresses mitochondrial respiration in mouth hearts and in isolated cardiomyocytes. So the sigma-1 receptor I mentioned earlier is a receptor that apparently was discovered not that long ago before its function was understood. It's expressed throughout our bodies. It's an interorganelle a receptor on the ER. And it turns out that expression of it confers neuroprotection in neurodegenerative disease. Sigma-1 activation limits meth-induced dopamine efflux, and in mice attenuates the meth-induced neurobiologic perturbations. And in the neurobiology literature, there's discussion about whether it would be a therapeutic target for meth damage in the CNS. It also turns out that sigma-1 receptor is highly expressed in the heart, and that knockout causes large hyperperfused mitochondria that looks similar to the FIS1, the attenuated FIS1 expressive mitochondria that I showed you earlier. It also suppresses mitochondrial respiration and attenuates CREB and phosphorylated CREB and FIS1. Overexpression of the sigma-1 receptor results in upregulation of CREB and FIS1. And it turns out that sigma-1 gene has a CREB binding site on its promoter, suggesting a feedback loop. It also turns out that in one study, there was significantly decreased sigma-1 receptor in the hearts of meth users and in meth-treated mice. So there are multiple pathways by which meth appears to result in apoptotic cell death in hearts. And possibly some of these pathways with further explanation will reveal treatments, meth-specific treatments, but currently, of course, we don't have anything like that. So does the route of administration matter? There's some theorizing that smoked meth results in pyrolysis products, which may be toxic and contribute to meth toxicity. We know that injected meth, as I said, accumulates in the pulmonary vasculature, and there are definite animal models of injected meth causing the cardiovascular pathology that we see. And oral amphetamines and methamphetamines definitely cause the psychiatric manifestations, and there are case reports of the oral amphetamines causing cardiomyopathy as well. So let's move on to talking about our meth cardiomyopathy patients and what they look like. So they actually look like our other dilated cardiomyopathy patients. They usually present warm and wet. We've all, however, taken care of patients who present borderline shocky or shocky. There are reports of them being more tachycardic than other patients. But I don't know whether this is just because they're presenting later. Most patients who present with meth cardiomyopathy already have a severely reduced DF. There are echo studies that suggest that they have worse four-chamber dilation than non-meth dilated cardiomyopathy. And there's that one 30-patient study that noted an increased incidence of biventricular thrombi. That's only a 30-patient study, but I would say anecdotally, that does seem to be the case. We see a lot of biventricular thrombi, or right or left or biventricular thrombi at Harborview in our meth cardiomyopathy patients. It's been reported that they are more likely to report chest pain, but I personally haven't noted that. And then, of course, they present with atrial ventricular arrhythmias. What's the prognosis? I culled the literature as much as I could to try to find any reports of prognosis. These patients are very hard to follow because they generally don't follow, aren't followed up. So they're typically database retrospective results that are reporting on the prognosis. This one seems about right to me, 16% at 18 months. That's sort of similar to this 24% at 36 months. And that to me seems similar to other cardiomyopathies. This was the BA study, which reported an astounding 28% 6-month mortality. I personally don't feel that I've seen that. And then this is that SURE study, the 30 German patients, and they only had a 10% 33-month mortality, which is way under what I think most of us recognize. But on the other hand, 73% of their patients reportedly quit methamphetamine. So what about taking care of our meth cardiomyopathy patients? So I didn't do a slide on the medical therapy because it's the GDMT that we use for dilated cardiomyopathy. It's the same, it's no different. And you guys already know it, so there's no point in going over that. But it's important to understand that, first of all, intuitively, stopping meth likely improves your prognosis. And but there have been a couple of case reports, including that SURE report, so case series of discontinued use resulting in increased EF, as opposed to less likely increased EF with continued use. Decreased symptoms. So blue is NYHA class 1 with decreased meth use with persistent symptoms. But what that means is that we can't just take care of the heart failure, we have to take care of the meth addiction as well. But unfortunately, there is no treatment or no pharmacologic treatment for meth addiction. So there have been a number of trials of different pharmacotherapies tried over the years, and unfortunately they suffer from being wildly inconsistent, both in who they enroll, what their outcomes they're measuring, what drugs they're using, and follow-up. The follow-up generally in these trials, the intervention generally in these trials is only like 12 to 15 weeks, which makes no sense to me at all. To me, that's like treating heart failure for 12 weeks. Obviously, that's not going to work. And this was a systemic review that looked at all 159 studies of pharmacologic therapies for meth use disorder, of which only 65 were randomized, of which only 14 resulted in publications, of which eight had no effect, 3 had some effect, and 3, the effect was unclear. There have been a couple of meta-analysis looking at these trials, and basically in both cases, the authors concluded that there was no particular pharmacotherapy that could be recommended based on evidence. The only thing that comes out of the trials is that determining how long people have been using, how heavily they've been using helps predict whether they can discontinue, which again makes sense. On the other hand, there was a trial that came out this year after all the systemic reviews and meta-analysis, which looked at injectable naltrexone and bupropion in patients who self-referred for treatment of the meth use disorder. And they saw an 11% response at 12 weeks. The response being defined as 3/4 of the urine samples being negative. I'm totally underwhelmed by this. And I suspect that if you follow these patients out further than 12 weeks, you would find that the response rate was even lower than that. So I'm not sure if that really changes the fact that we don't really have a medicine. It does seem like some medicines may decrease meth craving, so particularly the antidepressants. So I'm not saying it might not be worth trying, but I don't think we have a strong evidence base. On the other hand, behavioral therapies have shown some benefits. So cognitive behavioral therapy has modest benefit, but a number of studies have shown that contingency management works. So contingency management is when positive reinforcement is given for a treatment-related outcome. In this case, the treatment-related outcome is generally negative urine toxins. And a positive reinforcement is generally something tangible, often money. So a voucher that you can exchange for money. In this systemic review of 27 studies looking at contingency management, 26 showed reduction in meth use, and more so than in that pharmacologic study. So on the order of 30 to 7%. So there was variability. Longer intervention improved outcomes, but in these studies as well, the intervention was only up to 4 months. It also decreased other risky behaviors like men having unprotected sex with men and increased hepatitis vaccine compliance. Again, the predictors of outcome were length of drug use and amount of drug use, as well as lower monthly income, which may reflect the fact that they're getting a monetary reward generally. Seems to me that since there's only one thing that's been proven to help with meth addiction, that what we need is a public health response to figure out how to scale contingency management and have it be longer than 4 months. The VA has implemented contingency management on a national scale. I don't know if any results of that have been published, but currently no insurers pay for it other than the VA. I've heard through the grapevine that Washington Medicaid may start paying for it next year, but I don't know anything more about that. Seems to me that what we're going to need as cardiologists is creative ways to work with our addiction medicine colleagues. And Sarah Lady, who's internist on staff here, did her addiction medicine fellowship at UCSF, where she worked with an addiction clinic that was embedded in a cardiology clinic, and they provided contingency management for the addiction as well as heart failure management at the same time. And I think that that's what we're going to need. Unfortunately, what we're also going to need is a lot more funding and resources to help treat the addiction, as opposed to focusing only on the heart failure. There's another thing that I want to mention about taking care of cardiomyopathy patients is that their addiction may mean something else, which is that addiction is closely related to trauma. So the evidence on this is solid, that patients who have addiction are likely to have experienced trauma in their life. In particular, many of them have experienced childhood trauma. Similarly, patients who are suffering with addiction often are experiencing ongoing trauma. And certainly our homeless patients are experiencing ongoing trauma. And many of our patients are also experiencing the trauma of structural and systemic racism. All this is to say that everybody has a story, and it's not necessarily my business to know the story, but I think it does behoove me to understand that when I'm taking care of a heart failure patient who has an addiction, that the means by which they became addicted likely requires some degree of compassion, and that my understanding that they have trauma should probably reflect how I care for them. And there is this idea of trauma-informed care, which I don't know how many of you have heard about, but it is gaining national attention, and there's federally funded program that is calling for increased education among medical providers in how we provide trauma-informed care. And what it really means is lowering the barriers to care of patients who have suffered trauma, because a lot of them find it difficult to even come into institutionalized settings such as a hospital. What that mostly means, the pillars of trauma-informed care are providing a welcoming, safe environment, respectful, non-judgmental interactions, and in general, lowering the barriers to access. There have been a number of studies that have suggested or that have demonstrated that trauma-informed care improves outcomes in whatever system that it's being used, so improves housing stability in situations in which it's being used with patients who are homeless, decreases substance use in addiction clinics, decreases psychiatric symptoms in mental health settings, and improves engagement in care in primary care settings. So if I want to engage my patients and really take care of the heart failure, then what I want to do is provide care that is welcoming to them and not judgmental. What do we do at Harborview? So we have a staff of people who we didn't necessarily call it trauma-informed care. That's basically what everybody's doing. And we have a number of ways that we specifically address the vulnerability of our meth-addicted patients. So when somebody's admitted to the hospital with a new diagnosis of meth cardiomyopathy, then frequently one of the nurses or nurse practitioners will go upstairs and meet them and welcome them to clinic and show them where clinic is. And we may even discharge them straight to clinic. There's an actually discharged pharmacy nurse whom I've never met, but who knows the back line of our nurse. So if she recognizes a patient that seems particularly vulnerable at discharge and maybe needs to be plugged in right away, will call us. We do arrange very close follow-up, so generally less than 7 days. 7 days is often too long for these patients. And if they're going to leave AMA, we encourage the inpatient teams to send them out with meds anyway and tell them they can walk in without an appointment. So there's a number of things that we've tried to institute to build the trusting relationship with these patients. And one is the low barrier access. So walk-ins are allowed in our clinic. Anybody who walks in will be seen. We provide frequent calls and reminders to them. We see them very frequently. So heart failure guidelines suggest that you see patients every 1 to 2 weeks after discharge anyway, but we actually do that, or at least try to do that. And then we provide really highly coordinated care. So we've gone as a team to meet teams, the medical teams at Pioneer Square, at Neighbor Care a couple of times. Our nurses and nurse practitioners have met the housing case managers and RN case managers in supportive housing. We have the numbers, and they have our numbers. So we've exchanged numbers with street medicine programs like the homeless palliative care program and some street programs that were available pre-COVID that have largely shut down, as well as outside pharmacists and outside providers. We have a new pilot where one of our nurses and nurse practitioners is going into Harborview supported housing to see patients who haven't been able to make it up to our clinic. This isn't just for meth cardiomyopathy, but a lot of these patients are addicted to meth, and a lot of them have or do use meth, and a lot of them, I mean, they all have cardiovascular disease. They're followed by cardiology patients. We also tried to provide some incentives in clinic. So we have a few snacks, but we also have a staff-funded clinic fund, which can provide dining cards for some patients, and which also is funding a pilot program that was inspired by Sarah Lady's project in San Francisco. It's not contingency management, but it's an incentive program where select patients that we deem to be particularly vulnerable for not following up pull vouchers out and may get either a verbal affirmation or a small monetary cash reward. And this is not meant to be facetious. We also have a really warm, engaging clinic staff that our patients have told us repeatedly is the least judgmental, safest place where they have ever sought care. And I think a lot of patients initially come because they actually want to feel better or they want their cash reward, but they eventually come because of the relationships they form in clinic. We also provide really tight transitional care. As I said, we have a high-risk heart failure list. We keep track of our patients. If they're admitted to our system or anywhere else, then we typically will try to touch base with the team that's taking care of them. And the inpatient and outpatient pharmacists will touch base. And in terms of their medical regimen, so if somebody's living on the street and they have a new diagnosis of heart failure, it really makes no sense to send them home on six prescription bottles and instructions to take their medicines 2-3 times a day. It's not going to work. So it's really important to have a patient-centered med regimen. If this means that their medical therapy isn't the peak of guideline-directed care, which, by the way, was formulated in a patient population that was studied that looks nothing like our patient population, then that's okay. If we can titrate up on their medication regimen over time, then great. So we really encourage the inpatient teams to send them patients home on a regimen that makes sense for them. We then provide really impressive medication management by our clinic pharmacists. So we can assign them fast packs and bubble packs, but during the titration phase, we'll often have them bring in their Medisets every 1 to 2 weeks and fill up for them. And many of our patients who are insecurely housed will actually hold on to the medicines for them. So patient number 1, he was schizoaffective and very, very flat affect, and we were pretty worried that he wasn't going to have wasn't going to engage in care. But one of the clinic RNs went upstairs and met him, and we followed him very closely, weekly for a while. We have now 3 years out. We still see him every 2 to 3 months. He has our back line. We have the number of Bailey-Boucher, which is where he goes to pick up his medicines. So his medicines are delivered there, and he does show up there most days, gets a blood pressure, gets weighed, and takes his medicines. His medicines of necessity have to be once a day because he's only going to go to Bailey-Boucher once a day. He's not going to remember to take his medicines otherwise. This was the regimen he originally went home on. And this is what he has now. So some degree of up titration. He's never been readmitted, and he still uses meth daily. He did go through a slight period of time when he was in jail and then was walking around with an ankle bracelet, and he was interested in addiction management, but I couldn't get him into a clinic. And this is his echo. So this is his baseline. EF 19%. And then interestingly, at this echo, his right heart had gotten larger than his left heart. And he had this abnormal septal motion consistent with RV pressure volume overload. So I was actually worried that he also had meth pulmonary hypertension. I sent him to Peter Leary, who was actually kind of skeptical because of his left heart failure, but on right heart cath, his wedge was 3, and his PVR was 6, which isn't as high as Peter usually sees, but he did start him on ambrisentan. And this is what his heart looks like now. Actually, this is about a year after treatment. I don't have his most recent echo up here. And patient number 2, so we actually saw him twice weekly for some time. Then I've continued to see him weekly. So it's been 4 months, and he's made it in most weeks. He's still living in respite, but it's about to be discharged to supportive housing. And this is the regimen we've got him up on. Now, because he's going to be discharged to supportive housing, he's had pretty close med management by the respite nurses, and I don't think he won't get that anymore. And so I think he's going to need once daily medicines, which is why he's not on Entresto. We did enroll him in our incentive program, which we think helped engage him to come to clinic. So even though he's in respite, he didn't actually have to come. We do have other patients in respite who haven't made it. And he still continues to use meth and heroin. On the other hand, not only is his heart failure better, which I'll show you in a minute, but I think that probably contributes to the fact that his Amphetamines have resolved and he's off antibiotics. He's walking, and he actually cried in clinic when we showed him the results of his echo. So this is his baseline. I think I showed you that before. Estimated EF 12%. And this is him about 3 months after treatment, EF in the 40s. Not normal. I wouldn't be surprised if it continued to get better. It is my impression that people who continue to use meth, if they are taking their medicines, their EF can get better. And this is the staff that provides this phenomenal patient-directed, what I'm calling trauma-informed care, patient-centered care. These patients are not receiving, sexy new cardiology procedures, but I believe that their lives are improved. They definitely feel better. We're keeping them out of the hospital, and I'm confident that there are some lives that have been saved. And this is one man whose life, I believe, has been saved by these people. So these are the nurses, nurse practitioners, pharmacists, and clinic who go really above and beyond to provide this very patient-centered care, which I believe is going to be the essence of taking care of meth cardiomyopathy patients. Simply prescribing them a GDMT regimen isn't going to do the trick. We have to treat their addiction. We have to really provide this team-based care, which, by the way, is a heart failure guideline recommendation anyway. But I think I said that previously. But it really happens, as well as engagement with the community. So conclusion number 2, meth is directly toxic to the cardiovascular system. Long-lasting success is obviously going to require treatment of meth addiction as well. We're going to need to collaborate with addiction medicine as cardiologists in order to ensure that that happens. And immediate success is really, I believe, requires a team-based approach, providing this patient-centered care. I think that the cardiology community needs to add their voices to advocate for resources directed to addiction medicine, given that there's a meth epidemic right now, and that we're going to see an epidemic of cardiovascular complications of the meth epidemic, as well as directed to the psychosocial determinants of health that likely contribute to the fact that people get addicted in the first place. And this is an editorial in Circulation just earlier this year, in which they echoed some of these thoughts, which is that we as a medical community need to recognize that meth heart failure treatment is going to require a comprehensive approach and public health response. One more slide, which is, this is the number of meth papers produced over the last decade at the same time that meth use has increased. So other than our advocacy for resources to changing the psychosocial determinants of health that result in meth addiction and improving meth addiction services, we need more research. And that's it. I'm open for questions.
Stephanie, thank you for that. I just want to say, I think I had more patients with methamphetamine cardiomyopathy on our inpatient service last week than I've ever seen at Harborview in a decade. I had 8 really severe methamphetamine cardiomyopathy patients admitted simultaneously. And I mean, actually, I'll just jump in and steal the first question. We have a whole bunch lined up. But I wanted to ask you if you think, you've shown this alarming trend over the last several years, but whether things have gotten dramatically worse in the last year or so, and whether you think, or what you think the pandemic's effect on this major public health crisis might be.
Yeah, those are interesting questions. So I tracked actually the number of heart failure patients that were meth cardiomyopathy on 4 service weeks that I was on, and it was always over 50%. And a few years ago, we were admitting a lot of meth cardiomyopathy, but I agree with you. My anecdotal experience is that it seems like we're admitting more. We know from, I mean, you probably know this better than me, that during the pandemic, substance use increased. There's also a couple other things that might be going on, which I have actually no evidence. I have nothing to back this up, but I have had patients tell me that the meth is different. And I don't know, so that P2P synthesis of meth really started to take off after 2015. So it's been in the last 5 years, according to, I don't know if you guys know, but there's, the DEA has a forensic team that goes around the world to, particularly Mexico, when there are meth lab or factory, basically meth factory closure events. And they noticed this change in the synthesis around 2015 and later, and now it's almost predominantly this P2P. And like I say, I've had several patients tell me the meth is different now than it used to be. So I don't know if that has anything to do with it. I don't know whether it's just the numbers of meth use, which are clearly going up. That California study showed that meth cardiomyopathy is clearly going up. But interestingly, in that same study, they showed that even though meth-related hospital admissions were going up, in fact, I think I have this slide, even though meth heart failure admissions were going up, meth admissions were going up, meth heart failure admissions were going up more steeply. So I actually wonder whether there's something else that's happening other than just that more people are using meth.
Yeah, let me get to some of the questions here. One question, what would be your wish list for resources that you think would help patients with meth-associated cardiomyopathy improve their health? So it's the holiday time. I guess you get to share your wish list here.
Well, I mean, like I said, I think we actually need a public health response. We need public health responding to, I mean, we don't have enough addiction medicine docs, period. Like I said, that one patient I tried to get in and there was nowhere for him to go. And I have another patient that is right now he's just trying so hard to quit meth. And I have emailed the meth addiction clinic and, I think they're going back door to try to get him in, but they've told me that they're short on providers. They don't have enough providers. So we need more people we need the fellowships to open up, and we need more people training in meth addiction, not just meth addiction, all addiction. And then we simply need more providers. And, I think probably it needs to be, so I'm not a public health person. I'm just speaking off the cuff, but I think it probably needs to be city, county, state, federal, just public health dollars need to be going to addiction medicine. But the other thing is what I said, we keep talking about, we've had multiple grand rounds in the last year about the psychosocial determinants of health for cardiovascular disease. And we need to address those psychosocial determinants of health. Like we need to have there not be so many poor people who are uneducated and unemployed because they are more likely to use substances.
Lee Eschenroder applauds your efforts and the personnel who are working on this, and specifically asked where, urban or rural, and to whom, adolescent, middle-aged, et cetera, are the policy and public health efforts being directed, or where should they be directed?
So I don't know where they're being directed. I don't know that data. It's not my impression that there has been a major public health response. Although earlier this year, actually, Dianne Feinstein, who I can't believe, I didn't even realize she was still a senator there, but Dianne Feinstein and the other senator in California actually passed some state, thing in Congress, which is a statement that there's a meth problem and we need to address it. I have no idea what that does, but maybe what that does is open up the purses to funding. Meth use, so it used to be considered rural, but it's clearly now urban. I didn't show you the data, but there are that California study showed that urban use has gone through the roof as well. So it's really both now. But as far as I'm aware, I personally am not aware of aggressive public health funds going to this at all.
There's sort of an interesting question here, which is, has psilocybin, which has been utilized for PTSD, been thought of as a treatment for meth addiction? Obviously, a lot of interest around psilocybin right now. Have you heard anything with methamphetamines?
Yeah, that is really interesting. I haven't heard that. I don't know, but I know that they're considering it not just for PTSD, but for anxiety and depression. And like I said, there is no pharmacology that's been really proven effective in meth, but several studies suggest that antidepressants may at least decrease meth craving. So,
yeah. Dr. Linker asked about beta blockers. He said the first patient wasn't on one. How do you think about beta blocker use in patients who may also be using cocaine? Is the hazard of unopposed alpha overblown?
There's no hazard to beta blockers. I don't worry about beta blockers at all. Is the first patient not on it? If he's not on it, it's because we had to take him off. He used to be on it for sure. He might have been discharged off it, but he should have been on it. Now you have me curious. Yeah, he's on Matope.
Yeah.
So
this comes up a lot, this unopposed alpha question.
Yeah. So it's just a complete, it's I'm so sorry. It's the classic thing in medicine where somebody floats an idea and it takes off. And I've actually drilled down on the literature, as have other people. And there's just zero evidence that it's any problem whatsoever in meth. And the problem in cocaine was even, there's like one case report. I mean, it was to me, it was wildly overblown. So I have no concerns whatsoever about meth. Having said that, most of our patients are admitted severely acutely decompensated. So I'm not going to give them beta blockers at that moment, but we had all of our patients on beta blockade. And I actually, I noticed that I finished the talk earlier than when I'd practiced. So I think there's a bunch of stuff I forgot to say. And I wanted to say one other thing about treating patients who are in shock, which is that I personally have admitted several patients who needed support with dobutamine or Impella, or even one with ECMO. None of them died. They all resolved their shock and then still had severely reduced EF, but were discharged home. And there was a New Zealand study that reported on the 62 patients hospitalized with meth, and they also had a little handful of patients who were in shock, and none of them died either. And I have this idea that isn't a brilliant idea or anything, but that patients who already have meth cardiomyopathy after a binge use will have a sudden decline in their EF, either due to myocardial inflammation or to a Takotsubo-like syndrome, putting them in shock. And if you can get them through those few days, then they actually can recover. So I think that in most cases, people think it's a contraindication to use LV support, but my anecdotal experience is that that's not true. That you can, these are 30 people in their 30s and 40s, and we can still maybe hope to get them off their meth eventually.
I think we're at time. Stephanie, thanks so much for a fascinating talk, very important area. Thanks everyone for joining and the great questions, and have a very good day. Thanks all. Bye-bye.